Hello, and thanks for joining us this afternoon. Welcome to the My HCPC Standards webinar on digital skills and new technology. Dr. Kate Granger started the Hello, My Name Is campaign in August 2013. She was a patient in hospital, frustrated by how many care staff failed to introduce themselves to her. So her campaign asks people in health and caring roles to introduce themselves to their patients in order to make a human connection before they start doing the care bit. So without further ado, I'm going to introduce myself. I am Hugh Tregoning, Professional Liaison Consultant for Wales. I'm also a registrant of the HCPC. I'm a physiotherapist by background. I've worked in the NHS, in acute care, community, and also in the private sector. I do continue to practice to this day, so in a sense I have skin in the game in terms of how regulation is done. I'm joined today by Mark Boatel, Deputy Head Rehab Engineering at Swansea Bay University Health Board, and also Clinical Scientist, HCPC Registrant. And Mark will introduce himself in just a moment. So let me run over some brief housekeeping, if I may, for today's session. So in order to protect the learning environment in events of this scale, we are required to automatically disable cameras, microphones, and chat. We will be using the Q&A function here on MS Teams, so take a moment to familiarise yourself with where that is. Previous experience shows us, though, that even though we try really hard and there's a whole team in the background working on it, we're unlikely to be able to get to all your questions, but we'll endeavour to do so and publish many of them in the Q&A tab. So just a reminder that this event is being recorded. For everyone watching at a later date, a very warm welcome is extended to you. And whilst you may not be able to participate in live interactions, you are invited to contact us, connect with us if you have any questions or queries after the session. This is just a short plug for the previous My HCPC Standards webinars, which have also been recorded and are now uploaded and available on our website. Please do catch up on any that you may have missed. Secondly, I want to highlight that the HCPC website has a number of really useful resources for registrants, employers and members of the public. So I'd encourage you to go over, take a look, see what's there, and also let us know if there's something that you would like us to develop and look at in the future. So this is a second plug really for our student competition. I encourage you to head on over to the website. You can either use the QR code there or just search for it on the website. And this is about designing a learning session about health and well-being, and the winner will have a £300 voucher prize. So what are we going to cover today? This is a roadmap of our session. So we're going to start by talking about why regulation. Why do we need to regulate? We're then going to focus on digital skills and new technology. What's the reason for focusing on this in regulation at this time? I will then outline what the updated standards are, and then talk about how we might implement the changes. And then we'll land, hopefully, around the kind of key takeaways of this session. So why regulation? So this is a little trigger warning here. This section is going to talk about preventable harms that patients experience. Firstly, to explore this question, I'm going to talk about some vital statistics in healthcare. So there are estimated to be up to 9,000 preventable deaths a year in the NHS. It is also estimated that 1 in 12 experiences preventable harm. So the 9,000 figure is the equivalent of around the number of people that would fit in around 18 jumbo jets. So my question really is, what would the Civil Aviation Authority not do to help the country prevent losing 18 jumbo jets per year? And aviation itself can be a great example of learning from error, adverse incidents to drive safety and excellent care. So William Wilmer wrote that of every 100 British military pilot deaths during the first year of World War I, 90 came from pilot errors, 8 from aircraft defects, and only 2 from enemy action. Yet now, according to research by Harvard University, flying in the US, Europe, and Australia is actually significantly safer than driving a car. So your odds of being in an accident during a flight is 1 in 1.2 million, and the chances of that accident being fatal are 1 in 11. So what journey has aviation gone on? And that is an intended pun, bad one, I'll admit. But what journey has aviation gone on to get such an enviable safety record. So there's a second question around this, and that is around the data. How do you measure preventable error and harm? And some of us on the webinar may be in trades where that's actually quite difficult to do. So some errors in healthcare systems are more obvious than others. For example, surgical errors or medication errors are easy to measure. But what about inappropriate discharges? What about failure to complete sufficient assessment that leads to an adverse health outcome for a patient? How good are we at measuring these kinds of errors in a systematic way and learning from them? And do we have our own version of the black box, critical friend that helps us regularly think about and reflect on our own practice to identify when things haven't gone as well as they could? So what are the standards of proficiency? Well, the thought formula goes like this. The standards are a roadmap to good care and not sat-nav. It's like an ordnance survey map for hiking and not a GPS, kind of like the highway code and not a driving instructor. So the HCPC regulates 15 different professions, and even if it was just one, like the NMC and the GMC, how many multiple and varied contexts do the individual professions work in? So the standards are deliberately high level in the sense that they often won't provide specific or prescriptive advice on how to act in certain situations. To take the highway code, it lays out the laws of the road in an easy to understand language, and it helps when we learn to drive, or it might help us know what a certain sign means or who has priority at a roundabout. But when you're out driving, it's not going to help you tell you exactly what to do when you encounter a skidding car or a cow in the middle of the road or hazardous driving conditions and that sort of thing. So the code can be used in the court of law to determine the right course of action in hindsight, but it wouldn't necessarily give you really specific and drilled down advice for every circumstance. So another way of looking at this could be when you're planning to take a walk. Now, one of my local hills or mountains, if you like, is Snowdon. This is an aerial photograph of Snowdon, or a satellite image of Snowdon. So imagine if you were trying to get to the summit of Snowdon, which is marked by that little waypoint on the top there. If you look at it just from the satellite view, you can see what appear to be relatively easy ways up and more difficult ways up. So there's water obstacles, there's potentially some steep ravines, some big cliffs, and potentially further out there's some roads and forests and woodlands and marshy areas. So these are all the things you'd have to think about when planning your route to the top. And of course there are maps, and this is a map showing the established routes up Snowdon, and some are known to be technically more difficult than others. So you could plan your route based on the map and the known routes, but of course there are other variables like weather, your capability as a leader, the individual or the groups that you are leading, and so there's lots of factors to take into account to plan a safe and effective and hopefully fun route to the summit of Snowdon. And the standards are very similar. They may show established methods and routes to a minimally acceptable level of service, but they allow you the freedom to determine which is appropriate way to reach your goal or reach the summit in your context. So why focus on digital skills and new technology? So I'm going to introduce you to a friend of mine, some of you may have heard tell of and or interacted with in the last few months. Just for kicks, I'm going to call this friend T2000, and yes, that is a reference to the Terminator 1 movie, where a cyborg from the future, actually 2029, comes back to assassinate the mother of the future leader of the human resistance. So top marks to anyone who predicted we'd be talking about Terminator in this session. And of course, I'm joking. What I'm actually going to do is put the same question that I asked you earlier to a large language model AI system, ChatGPT. So I'm going to ask it, why is it important to regulate healthcare professionals' use of digital skills and new technology? So let's see what happens if we ask that question, and hopefully the video will work. So on this version, you type your question in the text box and hey presto, off it goes. So I'm just going to talk through some of the things it's covering. I realize there might be a slight delay on the video. So ChatGPT is talking about patient safety, quality of care, privacy and data security, ethical considerations, professional competence. And then it's going on to give a really good summary of its argument, really. So it's made some great points. If I'm being picky, it didn't mention about professional reputation, reputation of healthcare and the NHS, all of which are really important considerations when you think about why we regulate, and particularly why we regulate digital skills and new technology. But I'm going to read its summary because I think it's quite helpful. So by providing clear guidelines and standards, regulations help harness the potential of digital innovation while minimizing the risks. So that was all done in 24 seconds. Many of you may have played with ChatGPT, and I would encourage you to do so. And obviously other large language model AIs, it's a mouthful, do exist. So what's also clear is Terminator is on the side of regulation, which won't be a surprise to anyone who's seen the movies. So in the movie Terminator 1, one of the characters says, listen and understand that Terminator is out there. It can't be bargained with. It can't be reasoned with. It doesn't feel pity or remorse or fear, and absolutely will not stop ever until you're dead. And I say this tongue in cheek, but there is a deeper point with this. Technology changes very quickly, and AI is just one area. What about the potential use of digital tech and smartphones to monitor our health and to support management of conditions? And what about the growth in telemedicine, connected devices, smart tech and wearables, robotics, and many other technologies which are changing all the time? How will these impact our practice in the next 10 years? So if we go back to the AI example, it's of course very clever, but also predictably dumb in the same way that I as a human being is dumb. So what do I mean? Well, take the issue of bias. So AI is only as good as the data it relies on. If we use AI in practice to produce materials, documents, patient education leaflets, for example, are there potential ethical or safety concerns? AI doesn't have a conscience or a mature ethical framework and is vulnerable to bias and potentially manipulation. And perhaps these things will be ironed out in time, but it does exemplify a strong argument for keeping up to date with digital skills and new tech. Change is inevitable, and it's our job to adapt and respond appropriately to this change. So a further why for the need to keep abreast of the impact of digital skills and new tech is that of digital exclusion. So digital technologies now play a key role in the economy in many people's lives, and they do obviously have the potential to transform healthcare, especially in economically tight circumstances. But evidence suggests it's often people with the greatest health needs who are least likely to be able to engage with and benefit from digital services. So a recent King's Fund report, which will be available on the post-event resources, states digital exclusion is most likely to affect older people, those living with disabilities, ethnic minorities, the homeless, sex workers, people from Gypsy, Roma and traveller communities, people living in rural areas like me, people from low socioeconomic background, and those with low digital or literacy skills. Digital exclusion can be well exemplified by the stat around digital devices during the pandemic. So if you remember, we pivoted very quickly to home learning for pupils, and it's estimated that 1 in 5 didn't have access to a suitable device, and there were stories about children taking it in turns around the mobile phone to do their lessons, which must be really challenging. So these are some of the obvious dangers of a really fast pivot to new tech. And of course, there are many health inequalities today. So take just one. ONS data says that there's a difference in life expectancy at birth between the wealthiest and poorest UK men of up to 10 years. So there are cities in the UK where in the most affluent areas, men will live 10 years longer than their counterparts in the least affluent. Now, obviously, there are complex reasons for disparities in health outcomes, but digital exclusion is likely to be in that mix and may play a growing role in the future. So it does highlight the need for us to regularly reflect on practice and the service that we're working in and see who accesses those services easily, and if there are groups that don't access it so easily, and what could we do about that. So for example, one learning from this session could actually be to keep multimodal delivery options. Could you have a more manual process, or do you need more digital enablers or champions to support and advocate for those potentially excluded groups. So what are the updated standards? So hopefully you've been to some of our previous webinars. So we've talked about centralising the service user, registrants' mental health, equality, diversity and inclusion, and leadership at all levels. And obviously today we're focusing on digital skills and new technologies. So these updated standards in brief do place an increased emphasis on active language, and they encourage registrants to be proactive in applying the new principles. So digital skills and new technology. The updated standards ask us to recognise that confidentiality and informed consent extend to all mediums, including illustrative clinical records such as photography, video and audio recordings and digital platforms. It obviously ties in with existing standards on confidentiality and informed consent and reflects the changing nature of both opportunities and threats in the light of new skills and technology. Secondly, the updated standards ask us to use information, communication and digital tech appropriate to our practice and encourages us to consider the impact of different digital skills and technology on equity and access to healthcare, as we've just discussed. Updated standards also ask us to consider the use of digital record keeping. And previously, the standard said we needed to be able to change our practice as needed to take account of new developments or changing contexts. But this standard now specifically refers to new developments and technologies. So I thought it'd be useful at this point to cover some myths about the standards of digital skills and new technology. First question, do the standards significantly change the game around confidentiality and consent? And hopefully you've already worked out that the answer is no. So new technologies can bring additional threats and opportunities, and these may need to be reflected on and mitigated against. But the principles around confidentiality and consent are exactly the same. So a simple example of this could be around the sharing of information. So sharing key information is key to effective care. And new technology makes it easier than ever to share more information and faster, whether that's via sort of a digital portal or as simple as email or other methods. But that means that the risk of sharing something we shouldn't is also probably higher. So we may need to reflect on this, reflect on incidents and make sure our processes are robust enough to make sure that we've mitigated against these risks. So secondly, in the area of learning, do you have to learn all the digital skills and new technology relevant to you or to your practice? And of course, the answer is no. So you just need to use technologies appropriate to your practice. And of course, things like budget, organizational size, team skill set, and your level of influence and position will all have an effect on which digital skills and new technologies you may be able to access. The standards may ask you to upskill in an area, and most of you will do this already when you encounter a gap, say, in your service or in your knowledge. So for a good example of that is the use of telehealth during COVID. So many services weren't using it before and learned very quickly to adapt to use it during the pandemic. So thirdly, do the standards mandate that all notes must be digital at a certain time in the future, say September 23? And of course, the answer is no. So it is accurate that the NHS long-term strategy is to digitise patient records, and this can obviously have significant advantage. But again, it's all dependent on the context in which you work. Budget will have a factor. If digital notes are an option, they could be superior to clerical notes, especially if you've got messy handwriting when you're rushing, just like me. But you will need to explore the cost, benefit and risk of changing and not changing. Lastly, in the context of a changing landscape around digital skills and new technology, is the HCPC mandating that you have to learn that particular skill or that particular technology that perhaps they're using in a hospital across the county border, for example? And of course, the answer is no. So there's no specific set of rules around which digital skills you need to use and which technology you need to be competent in. And some of those things I mentioned earlier around levels of expertise, budget, autonomy to make decisions and commissioning and that sort of thing will play a role in that. So it's important to say some new technologies are genuine game changers, such as wearable devices in diabetes care. And these devices can be significantly superior to older technologies. So there are ethical questions about not offering them where we can, but in most cases with technology, it's not as clear cut as that. And therefore we need to use clinical judgment to make those decisions, and also discuss it with your line manager if you're not working on your own, that is, and do gap analysis, speak to your professional body, digital champions if you have them available. Lastly, I want to just very quickly reflect on this. So many of you may have read Stephen Covey's book, 7 Habits of Highly Effective People. Other self-help books do exist. But he talks about the circle of influence. So similar to the diagram on the slide. And the idea is that we spend a lot of time and energy focusing on things that concern us, but we have no influence over. So for example, things like world peace or climate change. So our opportunities to influence these things are relatively small. They're obviously very significant. And the same is true in healthcare. So what we have to control and influence will vary from context to context. And the HCPC doesn't expect you to have control over how your budget is spent or which technologies your trust board or organisation will invest in. Rather, we ask you to be thoughtful as you practice, which I'm sure you're doing already. Look for gaps in your service and focus your efforts within your circle of control and influence. So how do we implement these things? So another thought experiment here. Let's talk about leadership, because implementation and leadership are intrinsically linked. And of course, if you watched a recent webinar on leadership, you know that the standards now place a requirement on all registrants to show leadership at all levels. So we probably all have an idea of leaders we admire based on certain characteristics. But a key factor I'd like to argue is that leaders have the ability to see where their practice is, so be honest about that, and where it needs to be, and to plot steps in between to try and close that gap. So one part of the answer to the implementation conundrum is to look for gaps or be mindful of them. In other words, to practice thoughtfully, and that can only come from people on the ground inside your own unique context. The ultimate example of gap finding is in aviation and the black or red box flight recorder. So this is a photo of the recovered black box of Air Flight 447, which crashed in the Atlantic Ocean during a flight from Rio to Paris 2009 and lost 228 passengers and crew. The search cost 31 million euros and took almost 2 years. And one commentator described the search as like looking for a bottle of water in the middle of the ocean. So my question is, how keen are you, how keen are we to learn from adverse incidents, to look for gaps in practice in order to get better at what we do, in order to prevent harm and adverse incidents? As individuals and as organisations, would we look for 2 years to find the reasons for an adverse event, especially if that might open us up to criticism or potential cost? How comfortable would we be sharing the lessons of that investigation so others can also improve? And I'll leave that one with you. So taking the warning on board that we cannot drill down to every situation that you'll all find yourselves in or give specific answers, I'm going to try and help you ask some useful questions. And as you can see on the slide, we have each of the 15 professions represented by their own icon. And yes, before you ask on the Q&A, it did take me hours to find all individual icons for all your professions. And I realise I've been highly reductionist about what you do. And to all the videos out there, please don't message me saying no one uses those crutches anymore. I blame Microsoft for that. So starting with standard 6.5, this is around confidentiality and consent. I'd like you to just think about practitioner psychologist working independently from home, using home Wi-Fi for telehealth appointments. So she works in a home office and records notes digitally and has 2 young children. So there's some potential questions that she may need to ask. So what's the security like of the home Wi-Fi? Do guests stay who have access to the password? Are the home computers secure? Does she have a separate business Wi-Fi account? Would that be beneficial? The note system that she uses, does she know how secure the notes are on that system? So for example, if she works with sensitive industries like security services or the police, is the level of data security sufficient for those clients? And would a more secure system be better if not? And lastly, the physical setup. So is there a possibility that people may interrupt her during sessions, especially if they're counselling sessions, and can steps be taken to mitigate against that? So moving on to standard 7.7, so using information, communication and digital technologies appropriate to practice. So think about a speech and language therapist using AI technology to produce materials and content to support a patient who has communication challenges. So obviously this can be a fantastic way to generate large amounts of material, which could be really useful for the client. But are there potential issues around the efficacy of the information, especially if it's not appropriately checked? AI models may not securely deal with data as well. So there are examples of corporations asking AI to work difficult problems out and putting sensitive business information in those models without realizing that they're being taken away to a data center and processed and crunched and learned from. What also about potential bias or inaccuracies in the data source? And what is her employer's policy on the use of AI, or has her employer caught up? Does it even have a policy? And are there ethical issues posed by the use of AI in some contexts? So to be clear, it could be a fantastic way of producing really useful content at speed and free up valuable clinical time. But there's clearly some thinking to be done on it. So standard 9.3, use digital record keeping tools where required. So think about a physio working independently as a sole practitioner and doing home visits and writing notes clerically. If his handwriting is hard to read, especially on a busy day when rushed, then could he look at potentially using digital record keeping tools? So what if he needed to share information, for example, with a multidisciplinary team, or write a referral letter to somebody, or write a letter to the GP? Or what if the notes needed to be audited, or he simply needed to rerun outcome measures? So digital notes could help with all these situations, but obviously you would need to look at which provider he uses and the security of that system as well. And lastly, standard 13.1, so being able to change practice as needed to take account of new developments, technologies and changing contexts. So think about a healthcare scientist who uses 3D modeling of a patient's head to make bespoke protective headgear for someone who's repeated head trauma, who has repeated head trauma. So some potential questions. Does the scientist or the team have appropriate expertise to deliver this effectively? And does the benefit justify the cost, especially if you have a kind of systems approach to it? Is there equitable access to such approaches and techniques across the service? And if this is a really effective method in a complex case, can you justify not using this approach if it's available and feasible and unlikely to reduce harm for the patient? So what I'd really like to do now is give you a real life example of how one team has looked at a challenge and looked at patient harms and used digital skills and new technology to help overcome that challenge. So to do so, I'm going to hand over to Mark Boatel. Mark.
Thank you, Hugh. Such a pleasure to be involved in such a stimulating webinar. And my name is Mark Boatel. I work in a team in Swansea called Rehabilitation Engineering. And as part of that team, we are a specialist service helping those in the community with stubborn pressure ulcers, with a pressure ulcer prevention and intervention service. And as part of that, we're able to do a couple of areas of innovation and prevention. And I wanted to share a couple of those with you today. Next slide, please, Hugh. So I won't go into this in detail, and I'm sure a lot of you are aware of the cost of pressure ulcers. 4% of the NHS spend is on pressure ulcers. The personal cost, you could probably say, is far higher, and there's anything from loss of independence to infection, surgery, and in some cases death as a result of pressure ulcers. The other thing to note is that statistics say that 90% are avoidable. And what we really recognise is that those that are at risk don't really know that they're a risk. They don't understand the implications. One particular poignant patient that stands out to me, and he said to me, "I wish I knew the risks. It was the pressure ulcer that disabled me, not the spinal cord injury." And so that loss of independence is clear, but also the impact of not having that awareness from an early stage as to what the implications could be and the fact that they are at risk. And the second thing, and if we're really honest, we're seeing lots of inconsistency in terms of the how much informed and engaged the nurses and healthcare professionals are in doing something about pressure ulcers. And so what we wanted to do is to compile information, put it all in one place in an easy to access format in order to equip the frontline workers, and in turn would be able to engage vulnerable patients, and hopefully we'd see some prevention and improved management as a result. We started within our own health board, and we had over 300 community nurses and therapists using the app. We've had a period of development now and looking to take it out wider. Some of the feedback was that it has had a real impact on how I position myself and move once I realised how affected I was. And next slide, please, Hugh. So this gives you a little bit of idea what it's like. There's various bits of visual and videos and tools on there to help interact in a more interactive way. I'd hope to say that this is free to download today. It is free to download, but it will be available from next Monday. So please put it in your diary to have a look on the App Store. It's only available on the iPad currently. Other tablets are available. Next slide, please, Hugh. So secondly, and this is something I'm particularly passionate about, we go into care homes a lot. This problem isn't just in care homes, people in their own homes as well. And many of you may recognise this as a challenge, not just for pressure ulcers, but many people out there are not moving when they could be moving. They could be getting out, up and about a bit more, or maybe doing small movements within seating. And so we wanted to look at how technology could help those people, and maybe to help the people that are caring for them to recognise, oh, you haven't been up for 2 or 3 hours. Let's help you get up and have a little walk around. So as you may know as well, immobility is a huge risk when it comes to pressure ulcers. It's pretty much the fundamental one. And maybe there's something about a cultural shift here. When we do things about pressure ulcers, we put things under people, we put new surfaces under there. We maybe, if we're really astute, we might adapt their seating and change the surfaces in other ways. But do we do much about the time, and really how do we change that culture, engage and empower people to reduce the amount of time they spend in one position? So that was the goal, and we knew that technology could help it. There's very expensive pieces of equipment out there that could do it, but in some ways we just need to tell how long you've been sitting for, and so simple technology could be used. I was lucky enough to get some funding for a Welsh social care hackathon. That's hard to say, and that got me in touch with other people, some tech enablers, as well as some others within the field that were interested in collaborating. And to cut a long story short, we're at the stage where we're developing a bespoke app, and we're trialing out the equipment, and we're learning a lot. We did a massive piece of scoping with a care home, and that was really key to find out really what do they want. I think sometimes with tech innovation we can think we've got a solution, but without scoping what the end users, the challenges they have in that exact environment, it can be a bit limited. So next slide, please, Hugh. The main message I wanted to get across, though, is that I really believe that small tech solutions can make a big difference. And so if you think about any part of a patient pathway, people coming into you for a period of care and how they leave you as well, there's a lot that we could do to better support that process. Some examples are here, but that you've probably got various examples of things that you're doing within your own services, and that's the other thing to recognise here. I think a lot of us use technology without recognising it, and some of these things can make a big difference. So having a really informative website, for example, that tells them what they're coming to do and how to be prepared with their goals. Maybe we'll get more appropriate goals from our episodes of care when they know what you're there to do for them. There's been lots of people doing lots of remote consultation. Telehealth is a big thing, and different software available for that. Just getting bespoke feedback, that could be really a lot easier to do when using different tools like Microsoft Forms, and others are available. Another thing I'm passionate about is patients having their own data and their systems out there, and different services that are really moving on this far more than we are. But how do we really put patients in control of their data? Sharing data between services is a real challenge that the NHS has, and there is some some way behind the curve compared with other industries. In wound care, for example, there are some apps that are helping us with that. And then just a bit more technical here, but thinking about how we can measure the outcomes, particularly those of you that work in a physical sense with your patients. How can we digitize things and use software to tell us whether things are getting better or getting worse? So the take home really is, what will technology do to make things better? And in the end, let's not just do technology for the sake of it. We need to be making sure that it's either going to make things more efficient, more safe, or with higher quality for those that we serve. Thanks, and back over to you, Hugh.
Fantastic. Thanks so much, Mark. So interesting and really helpful to have your insight into how you and the team, because I'm sure it's a team approach, you've just incorporated digital skills and technology to solve a clinical problem and reduce harms. So we've also had some questions submitted in the Q&A. There's one in particular that I'd like to address around, I think I've kind of covered the question about AI, just in the fact that it could be really useful in clinical practice, but do think about sources of data, do think about data security, and think about sort of company policy and getting advice from your organization. If you work on your own, think about engaging with professional body, if you're a member of a professional body, and other experts in the field, and there will be some links in the resources which we'll share for you. A useful way of asking a question around that is to think about the internet, because we're used to the internet now. So if I was to say, how useful is the internet for producing content for patient resources, you would all, of course, say it depends. What are you asking? Where are you asking the question? And have you tried to eliminate bias and check for inaccuracy? So the second question that we've had submitted is around barriers to implementation. So what if you know what would help, but you don't have the authority, influence, or budget to implement it? What if there is resistance in your organization? And I think this is a hard one, but I would firstly think about really knowing and doing the research on the new technology or skill, have a gap analysis on hand about what needs it might meet, and sort of think about sensitively making the case for change. If you have a digital champion in your organization, can you link with them for advice, support, or advocacy? And remember the circles of control and influence. So you may not be in a position to influence decisions about which new tech are invested in or reinvested in, but you can still be engaged and highlight what your views are. You might want to put that in writing. And remember, you can speak to us, you can speak to the professional bodies if you want further information or support with that. So key takeaways: digital skills and new technology. So in regard to confidentiality and informed consent, remember that these are not new principles. Understand the opportunities and the risks presented by new technologies and processes, and where necessary, take steps to mitigate them. Use technology appropriate to your practice. So consider carefully the relative strengths and weaknesses of the technology you're using and access to it, and take steps to mitigate. So use digital record keeping tools where required, as it may meet all of the criteria for full, clear, accurate notes, which are not likely to be damaged or lost. But there obviously may be additional questions to think about when you're sourcing digital record keeping software. And be able to change your practice as needed. So you may want a horizon scan, join networks of support, speak to digital champions and colleagues, and work out what changes are coming down the line. And that brings us to the end of our session today. So thanks so much for joining our webinar. Hopefully you got some useful hints and tips, and that's it. Thanks for attending, and I hope you have a good rest of the day.